Well, thank you, everyone. It's while people come in and out, I'll just transition into the panel. We are now going to focus more specifically on the HIV Tb Connections, the similarities in both the challenge that the healthcare delivery system has, the unique aspects of the communities involved, and the critical role that both must play in working with governments to develop and strengthen the delivery system that focuses on both diseases. HIV, with the 1.3 million deaths a year, is matched with a 1.7 million deaths from tuberculosis, 10.4 million new infections annually. A little over 400,000 of the TB deaths are HIV positive people, and that overlap, as anybody in support of a medical delivery system knows, must be capable of recognizing, diagnosing, and treating both diseases in the same populations. In addition to that, our ability to use the platforms that have been built by HIV, the maternal and child health platforms, the family planning platforms, we must be smart enough to use the already existing medical infrastructure to add on services to this complement to expand to the needs of the patients that we are already responsible for and with. That shared responsibility as we move into an expanded platform to ensure that HIV and TB are diagnosed and treated, and as we move into the challenge that non-communicable diseases affords for that same population, we need to be vigilant, as President Clinton pointed out repeatedly, in not allowing any of the gains already achieved to recede in the HIV arena, in the TB arena, as we synergize with program convergence, and as we prepare ourselves as a collective shared responsibility to engage the NCDs and move to universal health coverage. I am proud to introduce you to three of our panelists today. Carol Kachinga is currently the Executive Director of the Community Initiative for Tuberculosis, HIV, AIDS, and Malaria, a patient-led organization based in Lusaka, Zambia. She's also a member of the Zambian Country Coordinating Mechanism, representing TB and malaria constituencies. In addition, she's founded and national coordinator of the Coalition of Zambian Women Living with HIV. Carol has had several international executive board positions and is also the president of the African Coalition on TB, ACT, and former chairperson of the Pan-African Positive Women's Coalition. As a TB and cancer survivor and a person living with HIV, Carol knows firsthand what is needed to help those who are literally fighting for their lives. She's been able to transform this personal experience into a political campaign to address TB and HIV, and has incorporated TB advocacy into her regional, national, and global activism. So, Carol.
Thank you, Eric. So I want to talk about a few points today, and I'll talk about 3 points that are close to my heart. As you heard from Eric, I'm a person who works directly with the communities and a person living with HIV and AIDS who's also a TB survivor. So I want to focus my talk today on TB treatment, prevention, and integration, speak a little bit around stigma, and also about the much needed domestic resource mobilization. So throughout the week, we have heard in different sessions, it has been said again and again that data tells us that there are people that are being missed. We have heard that 40% of the people with TB are being missed by the health system for TB diagnostic and treatment. And in 2016, only 39% of the estimated number of people living with HIV who had tuberculosis received treatment for both HIV and TB. The devastating fact is who we are missing. These are usually the vulnerable in society, the population, and these are the migrants, the young people, people living with HIV, and people who live in poverty. We have heard that there is data that tells us where these people are, and we have the treatment that can mean for them the difference between life and death. Sadly, we are still missing them just because we have not done enough to remove the barriers they face in accessing treatment. But even for those who are lucky to access diagnostic and access the treatment, you find that the burden of the financial burden falls on them. And by that, they end up losing a lot of money because then most of the burden goes to them and not in the system. So as Elena Baruna, I want to quote what Elena Baruna, a health economist who presented at the TB 2018 session. She said that even if the TB service is deemed to be free, 70% of what is supposed to be free, the treatment cost is covered by household, which drives families right over the edge into severe poverty. Now, when I come to the preventive therapy, we have IPT, which is another preventive therapy, which can save lives. And yet, most people attending this conference are not even aware of that. It is a simple drug that can help people living with HIV and AIDS not to develop a TB disease. And now there are short regimens for preventive therapy, which some of them last for 3 months. There are even some which now will be lasting for just a month, and hopefully a generic one, a version. So my question again is, why is it that there are very few people living with HIV who are accessing this particular service? We also have, we heard that there's a simple urine-based rapid TB diagnostic called LAMP, which is available, and it is a cheap and easy way to diagnose TB in a person with advanced AIDS. Yet most programs are not using it, and people living with HIV are mostly unaware of that. I'm talking about this here because this is the audience here mostly is of people living with HIV and AIDS, and in most cases we are not aware of what we have in the pipeline, what can save our lives as people living with HIV. We know that TB in a person living with HIV can be diagnosed rapidly using a gene expert, but most countries are still using microscope, which is totally unreliable. I've always been asked, which is the hardest part of getting TB while living with the HIV virus? And my answer has been integration of treatments. When I found out my HIV status in 2001 and that I had TB, it took me over 6 months of going back and forth to the health centers for me to be diagnosed. And at that time, I was a young widow. I had just lost my husband and I had 2 young children to feed. The emotional impact of that on me, and also the loss of finances, because I was just a businesswoman then. Instead of me staying in my little restaurant to work, I had to go to the hospital back and forth. That also fueled the stigma, because I'd have to close my shop to go to the health center to access my service. Once I found out that what I had was TB, and then also my HIV was confirmed, I now had to go to 2 different health centers. So I always say, it's not right for you to cut up one person. I'm Carol. You can't cut me up in half with one going to the HIV center, the other one going to the TB center. I had also, unfortunately, had Kaposi sarcoma, so the other part of me goes to the cancer clinic and all the other diseases that I had. So for me, if there was a way to have an integration of services, but also of the diagnostic equipment, if you could have an equipment that could diagnose, I go in and you're able to diagnose my HIV, diagnose my TB, and also my cancer. My cancer right now is in remission, but if I default on my treatment, then it will come up. So if there's an equipment that can help me diagnose that, that would be helpful. On top of treatment complications, because of stigma, thousands of people die every day from a disease that is preventable and curable. Without addressing the treatment gap, the world will not achieve the NTB goal. And without prioritizing the high-risk groups, we will not close the treatment gap. For that, WHO put the End TB strategy, which most of us are aware of, But like any other development goal, the most significant barrier to effective TB treatment is lack of resources. This is why the high-level meeting on TB in September for us is very important and vital in making these issues a real priority at the highest level. And in order to realize it, public systems are now reaching out to our governments with help of civil society and private sector must ensure availability of existing and new medications, and nutritional support for people taking the medications, full psychosocial support, particularly for people with drug-resistant TB, and accessibility to aids for clients suffering disability, such as deafness that is caused by the TB drugs. At national level, in countries with high TB burden, we need governments to increase their commitment with bigger budget allocations for health and specific allocations to national TB programs. At a global level, I would like to say it is important for donors to continue supporting civil society movement. People always say there was strong movement around the HIV movement than the TB movement. We are not funded well. If we are funded well, we will do much, much more work. So they should continue because the work we do is we support and we complement government efforts. I don't know why, I think we heard from what Eric Goosby said, why when 10.4 million people who develop TB every year is not making us panic. That is over 4,000 of us people living with HIV dying every day. I say this at all AIDS conferences. I don't understand why we people living with HIV are not really coming to join the movement for TB to do more work around that. Because if we do not, the investment that has been put in us from the HIV sector will be lost. I've been on treatment for 17 years. I could have TB and within a week I would die. So the 17 years that has been invested in me is going to go away. This is a global health risk that should make our heads of state show up at the TB high-level meeting in September and commit to reaching everyone. Make civil societies fight for investment policies and donors back the efforts up to the increased resources. I'll end to say it was at the high-level meeting, the HIV high-level meeting in 2000, attended by panicked and angry HIV activists, mostly people living with HIV themselves, government officials, civil society representatives, researchers, that helped shape a radical transformation in the global fight against AIDS. And that effort is nothing when almost half of the people living with HIV are dying of tuberculosis. I say, let's take the same commitment to the TB high-level meeting and work to close the gap in testing, treatment, and prevention, including reaching 40 million people with quality diagnosis treatment by end 2022. I thank you.
Thank you, Carol. That's really terrific. I was on the phone the other day with a group of organizers for the meeting. We were talking about a few of the logistics and specifics, including my introduction to Dr. Paul Farmer, when someone emphatically stated, who doesn't know who Paul Farmer is? So I'm going to make this short. For those who do not know or need a refresher, Paul, physician, anthropologist, chief strategist, and co-founder of Partners in Health, professor and chair of the Department of Global Health and Social Medicine at Harvard Medical School, and chief of the Division of Global Health Equity at Brigham and Women's Hospital in Boston. He also serves as a UN Special Advisor to the Secretary General on community-based medicine and lessons from Haiti. Dr. Farmer has written extensively on health, human rights, and the consequences of social inequities. But this is his official bio. What it doesn't say is that Paul is an extraordinary humanitarian who has helped countless people in developing countries around the world, beginning in Haiti. But it is known, he is known as the man who could cure the world. To me, that sounds about right. A colleague, a friend, and a compatriot in arms for many, many years, Paul Farmer.
Thank you. We had a conference call, as one does, by the way, thank you. We had a conference call to discuss the conferences. I'm going to put these on because I don't need my notes. Last week, and there was a division of labor being worked out, and I said, well, I'd really like to talk about therapy and diagnosis. I mean, that's kind of my job. And there are new therapeutics available for the first time in 20 years. Available, I'll go back to that in a second, as Carol just mentioned. However, when I got here today, and I heard there was a clip from the movie Bending the Arc being shown, I said, well, which one was it? And I saw that it was Melquiades. And I just want, instead of to talk about Dilamidid, bedaquiline, urine dipsticks, just stop and say, well, what became of Melquiades? What's he doing now? And I happened to hear from him yesterday, and he is now working, this young man that you saw who had extensively drug-resistant disease and had been the recipient of multiple empiric courses of the wrong treatment, which was, by the way, at the time national, but also global policy. Not an accident, in other words. Not a problem of his culture. If it was a problem of culture, it was a problem of the culture of public health that set standards too low for other people. Well, Melquiades now, and I remember this sitting backstage during the last session, inspired to say this, Melquiades is now a full-time health activist. That's what he has been doing for the last couple of years. Some of you may have met him at tuberculosis meetings. And in order to become an activist, you have to be alive. And this is something we learned, I think, or at least I learned it in the 80s, Carol just mentioned it, is that we all have a great debt of gratitude to people who engaged in health activism, not only on behalf of themselves, but on behalf of other people. They were not socialized for scarcity for other people. Now, this is the heart of the problem of tuberculosis. We can and should talk about new therapeutic regimens. I'd be glad to. I was supposed to make this 2 minutes, which I've already failed to do. We can talk about new diagnostics. We should. As Carol points out, in order to do this work, you need staff, you need stuff, you need space, and you need systems. Safe space, meaning places where you won't get tuberculosis when you follow the recommendations of your nurse or doctor. Meaning, show up for clinic, well, you'll be showing up to an unsafe space. But it's more important to remember that the biggest problem facing us, or the biggest problems, are structural around poverty, gender inequality, disregard for others for many reasons, and they are the fruit of an adoration and worship of a neoliberal order where everything is a commodity and every person can have a price on him or her. Looking back over the history of of medicine and public health for the last century, it's been the same story. When rifampin, which made short-course chemotherapy for tuberculosis possible, when it was introduced in about 1970, just look back and you'll find articles in medical journals asserting that it is not cost-effective, feasible, or sustainable to use that drug. And it would happen later with antiretroviral therapy, and it will happen with second-line anti-tuberculosis drugs, and new therapies for malignancies, malaria, etc. This is a general problem that we in medicine, public health, and health activism need to understand as a general problem, which is, again, we think that other people need less than we do. We are willing to advance policies that set as a target inferior quality therapy for them. And by the way, they're mostly black people, brown people, and poor people. And most of all, back to structural problems, we're talking about a shifting epidemic. The goal today is to talk about tuberculosis and HIV, and again, it seems appalling that it is still possible for Carol, and I will bet blessing, to say that the leading killer of people living with HIV is tuberculosis. Now, if that isn't a problem that already has solutions, including some new ones that would make diagnosis and care more tolerable for those lucky enough to receive it, if this is not where we were in 1981, thinking about HIV, no identified pathogen, no identified therapies. It was bad enough that it took a decade to roll those out more broadly, and we failed abundantly in that process. But it's worse when you contemplate the problem of tuberculosis. Again, decades of policy setting our targets too low, setting our objectives too low, and always with the argument that it was too expensive for them. Now, to turn this around, which has been the focus of a lot of these discussions of how to marshal the same kind of activism that we saw in the 90s and early aughts, marshal those on behalf of tuberculosis, requires going to meetings like this. Thank you all for coming to this meeting. I'm a little meetinged out myself. But we can organize ourselves to interrogate some of the claptrap that comes out of our own circles. These are not people saying, this is a different problem than having Jesse Helms attack people living with HIV, or this is a problem of our peers thinking it is okay to set our standards low for them, for others. And even though I swore to be stick with a very material note, talking about new therapeutics and new diagnostics, the general problem remains that one. Thank you for allowing me to participate.
Our final speaker is Blessy Kumar. I'll introduce her, but I wanted to challenge the audience to start queuing up questions that you may have that could be to any of the speakers. We'll go right into the Q&A after the discussion, and we'll take questions directly from the audience. Blessy Kumar, also joining us today, the co-founder and CEO of the Global Coalition of TB Activists. A TB survivor herself, she's been a TB advocate and champion for decades. Blessina has worked with TB communities to bridge the patient-practitioner divide through patient literacy at the community level and policy advocacy at the macro level. She spent the last decade advocating for inclusion of infected communities in TB policy and implementation globally. Community indicators are surfacing in country reports on TB as a direct result of her leadership and her advocacy. In India, she has led the civil society movement against tuberculosis, lobbied decision makers, and worked with parliamentarians to raise TB awareness. She's also the co-founder of Touched by TB, the national coalition in TB of people affected by TB. Blessina serves on several boards and communities, contributing richly to the people and populations burdened by tuberculosis in her country, and has moved into global advocacy.
Thank you, Eric. Good afternoon, everyone. So seizing the moment for TB is very accurate. We've been trying to seize it now for many years. Talking about TB and HIV integration and the challenges, it's important to understand why this integration is a must and is not a choice. If we want to end both the epidemics, we cannot not do this. Now, to understand why and the enormity of what seems to be a hopeless situation, we must actually look at the figures. Both Eric, Carol, and Paul have alluded to this. But let's just quickly try, if we can, and swallow these numbers. 1/3 of the world is infected with TB. In 2016 alone, 10.4 million new people had TB. In the same year, 1.7 million people died from TB. And TB is one of the top 10 causes of death. When I spoke at the TB 2018 pre-conference, I said it's like having 6 tsunamis in a year, or 13 jumbo jets crashing every day. Now, a person living with HIV is 26 to 31 times more likely to develop TB, to develop active TB. Now, of the 1.7 million lives lost to TB in 2016, 0.4 million were people living with HIV. TB is the leading cause of death among people living with HIV. But of the estimated 10.4 million, we are only able to find 6.3 million. Where are the other 4.1 million? Key populations, underserved populations, criminalized populations, people that the world doesn't want to see, no one knows. We need to find them, and it's the communities that will find them if enough investment goes onto it. Now, the global rate of reduction is a shameful 1.5% per year. And there's a big gap of $2.3 billion short in the investment. Now, if this isn't reason enough for TB and HIV to be integrated, for us to be working together, I don't know what is. On the ground, the programs are very vertical. There's really no integration happening. The 2 responses are vertical at country level, with very minimal connection. In TB, access is still a huge issue. TB is very top-down, is very medicalized. Our language is medicalized. And it's definitely not a people-centered approach that upholds the rights of the individual. In TB, we're also very happy with very little. There is no demand. And we are very happy sometimes with crumbs off the table. So what is missing is that strong activism from the affected community demanding for what is rightfully ours. The TB response is driven today by donors, by the pharma companies, by the international technical agencies, but not by the community. It's not a community-led response. The lessons learned from the HIV activism need to come into TB. We need HIV communities and activists to demand for TB services, for a community-led response. We need to make sure there's access to TB medications, both current and new. I urge my own government, the Indian government, and governments of other countries to support and stand by South Africa for the inclusion of TRIPS flexibilities in the UN Declaration on TB. I would like to invite my colleagues to say a few words on that at this time.
Comrades, I come from Treatment Action Campaign, South Africa. I thank you, my comrade from India, Plessy Kumar, for giving us an opportunity to have our voice heard in the TB session. Comrades, what is killing our people with HIV today? Is it TB? So yes, we must seize the moment at this session, as this session says. But far away from all of us, from community groups in New York, a document is being negotiated that will affect how our government sees the moment. Could any of us imagine that the objective of one of the countries will be to seize our drugs? You all have heard about UN high-level meeting on TB, which will take place in September 2018. And there will be a declaration signed by all countries. The high-level meeting and the political declaration will form the basis of my government, your government, all our governments, to commit political will and resources to fight TB. But the language that will ensure access to affordable generic TB medicines, vaccines, diagnostic may be not in that declaration. When our lives were in danger in 1990, our President Nelson Mandela was sued by Big Pharma to stop generic medicines from reaching our people. We came on the streets. The whole world came on the streets, and the whole world and the World Trade Organization and all countries, including United States, signed the Doha Declaration. This declaration recognizes the right of our government to take legal measures to ensure access to generic medicines. That language has been in every HIV declaration in the past 2 decades. That language is the Sustainable Development Goals. Why should not be in the TB high-level meeting declaration? Why is the United States bullying our governments to take this language out? Ambassador Gusby, you were leading the US response on HIV for many years. Why you have not spoken about what US is doing? UN Ambassador, we call on you to immediately support language in the declaration using TRIPS flexibilities to ensure access to affordable medicines, vaccines, and diagnostic on TB. Why UN is silently supporting us? Why is the government of Netherlands that is hosting us, that has pledged to put their power and political will behind HIV, staying silent on this? Do you not know what is killing people with HIV? Or you only concerned that you will get on flights and bring TB to you?
Please allow the presenter to continue. Please allow the presenter to continue. Please allow the presenter to continue.
Thank you very much. So this is what is really needed. More of this in TB. There are some weak attempts, but we really need something that will enable a strong response, that will shake the powers be to act, to be part of the decisions that concern us, to challenge the powers that exclude us, to be more than mere recipients of care, but valuable partners in the response to TB and HIV. Thank you very much.
Thank you so much for those comments. While people have thought about their questions, they could come to the microphones that are in the middle of each aisle, and feel free to, I'm actually going to stand up here to see this. Yeah. And I will ask you to speak. While we're waiting for you to queue up, I want to just give the panelists an opportunity to comment on how the high-level meeting is supporting the issues that you brought up, a role and place for the community to be given an opportunity to input and to react, input and engagement around the document itself, and then how you hope the activities in the high-level meeting are precipitating activity back at home. So just in general.
Okay. Thank you. I think in a way I could say we have been supported because a few months ago, we had the TB high-level hearing for civil society, where we were given an opportunity to go to New York to the General Assembly to be able to speak and issue and give up our issues. But at the same time, we are also running campaigns in most of our country where we want to ensure that our heads of state come to the high-level meeting. Another thing that will help is if we can be part of our delegations at country level so that we input our issues into whatever is being talked about at country level. But then on top of that, even with the documentation, especially at global level, we have been given an opportunity to be able to input in that. So with this particular process, I feel we have not been left out. We have a part, at least we have a seat around the table in the process. We're just hoping and calling on all the other government and other civil society and just other people who can support us to ensure the highest level of participation, and for us heads of state. I know for me, most of my MPs are here, people from the ministry are here. When you go back home, I hope we can work together to ensure that our president is also one of those people that take part at the TB high-level meeting.
Since I feel ambivalent about whether or not our head of state participates, I'll pass it to Blessing.
Thanks.
Thank you. So I think to ensure that the high-level meeting doesn't just remain an event, I think two things are very much needed. One is high-level heads of state presence, for which, like Carol said, we're all working. I'm working with my Prime Minister's office to ensure that my Prime Minister is there leading the delegation. And we are also, as the Global Coalition of TB activists, helping other countries, other activists in other countries to make sure that their heads of government and heads of state attend that. Number two is a very strong declaration, which is why we saw all this activism. The language in that is very important, because that's what governments will actually sign on to. That's what you can hold governments accountable to. So I think two things, and the third thing is, of course, we need to have as many people from the affected community as possible. That needs investment, but unfortunately, when it comes to investment in TB, donors step back. So I would urge that donors actually invest so that we have an effective TB high-level meeting, because we're not going to get this chance again. Thank you.
Thank you, Blessy. Very good. Let's turn to the questions. We'll take 3 questions at a time and then allow for responses and then take 3 more. Sir.
I'm Dr. Gilada from AIDS Society of India. I would like to forewarn people in advance that number of anti-TB medicines are vanishing from the market. No pharmaceutical is interested in producing anti-TB medicine because the cost of production is high and cost of selling is low. And currently IPT, that is isoniazid prophylaxis, if you have to hunt for 50 shops, you can get from 1 shop. Rifampicin is also going to vanish. So you will have to play a high advocacy role. Government of India has done enough work for HIV and TB work, and they can do wonderful. And currently India is the only country which can provide low cost accessible medicines, like in HIV. 92% of the people in the world are accessing Indian medicine. Let same thing happen about tuberculosis. So I would like to request all of you to make a good advocacy effort that anti-TB medicines do not vanish from India. Otherwise, there will be chaos, and MDR TB is more dangerous than HIV. And second problem is medical doctors. Third problem is hospitals. No private hospitals are interested in taking MDR tuberculosis patient as inpatients. A lot of doctors are not interested in working. So we have to have some policy incentivizing doctors and hospitals. Thank you.
Thank you.
Hi, I want to say thank you for a great session. I'm Dr. Susan Michael Stresser, and I'm the Director of Implementation at ICAP at Columbia University. But most importantly, I'm proud to be a nurse. And I had to take INH for 9 months because I was working in a setting that had a lot of TB, no masks, no gloves. And I wanted to ask if you could add to, or how we could add to, the meeting in September to talk about health workforce safety. I know in India, health workers have died and been infected, and I work in many countries, including Sierra Leone, and most of the clinics where we work, there is still no running water. And I think to fight TB, we know we're going to need nurses, and they need to stay healthy. So however we can get engaged, please let me know.
Thank you. Sir.
And my name is Martin Owino, a member of parliament from Kenya, and I want to appreciate what Dr. Farmer is doing in Rwanda. Actually, we are going there in September to benchmark. But there's an issue of community health workers, which I'm really struggling with, and I want to bring it in a bill form, so that instead of calling them volunteers and stipending them, they can be put on a payroll. Because I believe early detection and disease management can really save money in the lower tiers than referral to the higher level of services. So my question is, in your experience with the community health workers in Rwanda, because I understand they even give directly the ARVs to patients, and that has really lowered the resistance. I would like really to get that. And lastly, when it comes to TB, the issue of nutrition has not been addressed. Administering medication into an empty stomach is not only ethical, but really gives side effects, and patients can really leave medication. So as we advocate integrated services, where is the nutrition left? Thank you.
Thank you. David, go ahead. do the last question.
Sure, David Bryden with Results. It's been a fantastic panel, and thank you so much for all the leadership on the stage. You know, when it comes to TB, we're often told, those of us working on TB, why aren't you as loud as HIV/AIDS activism? To me, the responsibility actually lies with the HIV/AIDS community to help get this right, to integrate services. You know, it's the responsibility of clinicians, of implementers all across these countries to use the existing tools. You know, the LAM test, for instance, TB preventive therapy. I want to ask everyone in the room sitting here right now, what is the obstacle? Or what is the obstacle? Why does this take so long to get people on preventive therapy? Why is it that so many people living with HIV/AIDS don't even know that they're at risk of TB and don't even have that TB literacy to know what the interventions are that would save their lives?
Thanks, David. So let me turn to the panelists and have them cherry pick any of those issues that you want to just go with, and then we'll just pick the discussion up from there. So anybody want to start with any of those questions? Carol?
What's that? I wanted to start with the one, I think, from the gentleman who spoke the last, David. On HIV activism and TB activism, why is it different? I think on top of what David just mentioned, there's also the issue that with HIV activism, the activists were well funded, and even the information, we're given a lot of information. With TB, it's still a very medicalized kind of disease, so it makes it very difficult, because when you're going to advocate, you're supposed to fully understand what you're going to advocate for. Again, when it comes to TB literacy, those are things that we as civil society, which is why we keep saying the donor should keep funding the TB movement, so that we can simplify the TB information and, you know, have treatment literacy. I started my work as an HIV activist, and it was easy for me to stand up and talk about the HIV life cycle. There are certain times I would stand and talk about the HIV life cycle. When I get off the stage, somebody would ask me, "Are you doctor?" I would say, "No, I'm not a doctor," because I was given information to understand the HIV life cycle. So if we are funded and we have all that information, we are able to go out there and give the treatment literacy. Community volunteers, it's something for people who are coming from a country, it's something that I'm pushing for. The community volunteers, I always say they are the foot soldiers. Without the community volunteers, a lot of the health centers would be closed, because most of our health institutions are understaffed. Our doctors and nurses cannot go out to carry out the intensified case finding. We need the volunteers to go out and find the cases. We are talking about ending TB by 2030. We need to find the missing cases. Who does that? It's the foot soldiers. And they need to be paid. So it is something that I'm sure most of us, Blessy, Paul, is something that we are always pushing for, to ensure that they have to be funded. So it's something that we are working on, and if the donors out here, we are really asking that they be funded.
Very good.
Thank you. Thank you very much for commenting on Rwanda to the Honorable Martin from Kenya. I would say something that also I think gets to David's point and request for comment. You know, standing here and talking about neoliberalism, I don't do that during rounds at the hospital. But both of these questions, the ones that I would, you know, and were addressed to me, or I'm interested in, one, financing community health workers, and two, what was David's point again, the specific one? I'm going to go back to medicalization in a second. David, hold that thought. The bigger problem, I remember you said, what explains, you know, this failure of implementation, this long gap between discovery and delivery. You know, we can't do a brain biopsy of everyone who's retarding progress, although there are times when I think it might be an attractive idea. So if we're not speculating that someone's motives are base, evil, villainous, etc., those things exist in the world, of course, I'm not disputing it. But if you go to the term medicalization, it's not that the problems are over-medicalized, because a lot of medical doctors and even nurses don't know a lot about some of these problems. They're not the obstacles, and as David said, there need to be more of them engaged in this struggle as an obligation. So since all of us are flawed and weak and all the other things that humans are, what is it that we can do to make sure that community health workers are compensated, trained, compensated and retained? They won't be retained if they're not compensated. And what can we do to shorten that gap between discovery of something, you mentioned the urine dipstick test I was going to mention, between discovery and delivery? Well, I think one of the reasons none of us, or at least I don't think anybody in this panel, is disparaging the notion of universal health care is that sometimes changes in policy and law entrap us into being more decent humans. That's why Blessing is saying we have to get the language in this high-level agreement right. I personally prefer low-level agreements and low-level meetings, but we can entrap ourselves into doing the right thing, such as making sure there's a shorter gap between discovery and delivery to those who need it both. But also, why do we end up justifying such absurd things as suggesting that someone who you're asking to work for 30 hours a week should be a volunteer, a community health volunteer, or pay them with a bicycle or something? I was here in 1992 in Amsterdam at the AIDS meeting, since it couldn't be hosted at Harvard. And it was the same story back then, talking about, well, we can't pay community health workers, so let's give them a bike, or a basket, or a coupon for the beauty salon. I mean, it doesn't seem unreasonable to argue that people should be paid for their labor. We need to trap ourselves into decency through legislation and policy change. That's why some of us clinicians are here.
Thank you. I'll just address the point about nutrition that our colleague from Rwanda raised. I think it's a very important point, and we need to actually look at a whole package of care. You cannot just give medicines, because people cannot take them on an empty stomach, very rightly said. And I think working in TB for decades, I also realized that it's not just fighting bacteria or a disease. It's actually fighting for justice, because it is a question of justice. It's trying to invert the power dynamics, because TB response is so top-heavy, so power-heavy. And the people at the bottom, who are mostly the people who are affected, the marginalized communities, the health workers at the end of that service delivery, who are getting further marginalized and not paid for work. So I think it also is a question of inverting that power dynamics. And for me, that's what capacity building and empowerment actually means, because it's only a community that has the capacity building and empowerment that can demand for services. Thanks.
Can I add to that, Carol, and again to the Honorable Martin, because parliamentarians obviously are the very people who do enact laws, right? In fact, one of the best American parliamentarians in history is here today, Barbara Lee, she's taught me a lot over the years. I'm not from California. She adopted me and other activists fighting for health and social justice, and then translated that in, whenever possible, and it wasn't always possible, into legislation that provided basic social protections. And, you know, around HIV, in every country there is legislation. Most of it was punitive and had to be undone with forward-thinking people like Congresswoman Lee. On the nutrition front, if we end up doing what we do around, well, should we use bedaquiline, should we pay community health workers, or should we not? You know, these ludicrous policy exercises that are so common in public health. If we do that with nutrition, as we have, if we continue to do that, we're doomed. There is no way to treat a consumptive disease without nutritional support. It doesn't work, right? So wouldn't it be better to, in a sense, and I'm not disputing what Blessing said, what Carol said, I've done that twice now. It would be better to say that this is part of comprehensive care, as Blessing said, and to demedicalize it in the sense of making sure that everyone can participate in discussions about matters that affect them directly, while encouraging nurses, doctors, and others to get more deeply engaged in the fight for health and social justice, to David's point.
You know, I'll just, I've been asked to wrap it up. I just want to say that the movement into tuberculosis for me and my own personal journey, from a career dedicated to HIV, gave me a startle to see how our coordination and kind of a village, it requires a village to put a treatment system together, had not permeated the rest of our medical world. And as we moved outside of the United States and Western Europe into places most heavily burdened by both HIV and TB, that was even more so. But I really want to underline the inequities that it reveals. HIV revealed disparities that were unacceptable, but they were relatively new in that this disease emerged in 1981. Tuberculosis has the distinction of having been there before medical delivery systems were stood up thousands of years ago, and became part of the structural response in most medical delivery systems, and at a very early stage was, as drugs were developed, marginalized, pulled off of the core integrated primary care effort of any given delivery system throughout the world. That kind of divergence put it in a separate, disconnected dialogue with itself, and it became comfortable in that space. And the wonderful things that we have seen over the last decade or so is tuberculosis understanding it improves its ability to identify, enter, and retain people in care if it is positioned in an integrated model. However, the structural impediments to that are significant, and to pull that system into the primary care system is a very difficult task, because, as Paul alluded to, it requires a dismantling, which people resist for reasons that have nothing to do with the ability to deliver a higher quality of care. So I really want to echo the importance and correctness in looking at disparities, and the social inequities that support or create or expand those disparities need to be fully understood and repackaged so we can dismantle those to not create barriers of access and retention in the delivery systems that are already stood up. I think, finally, I just wanted to echo the plea for healthcare professionals, and I include healthcare workers in that statement, need to be a part of the advocacy system in asking and demanding that that integration occur with tuberculosis, and that tuberculosis be aggressively responded to and not an afterthought. We need to understand the met and unmet needs in communities that are burdened with this, and that needs to be our marker for how well our integrated delivery system narrows that disparity. I want to thank the panelists for all of their wonderful thoughts and reflections. I want to thank the audience for their patience and kindness with the presentations and the panel discussion. So thank you very much.
Ladies and gentlemen, please welcome Anton Pozniak to co-present the 2018 IAS TB HIV Research Prizes.
The 5 $2,000 IAS TB HIV Research Prizes are incentives for for researchers to investigate pertinent research questions that affect TB-HIV co-infection and operational effectiveness of implementing core collaborative services, including service integration research. The prizes are presented to the 5 top-scoring abstracts in any of these areas. I'm pleased to present the 2018 TB-HIV Research Prizes, which are awarded to Fiona Creswell of Uganda for her abstract entitled Expert MTB RIF Ultra for Earlier Diagnosis of TB Meningitis in HIV-positive adults. Joseph Kavanagh of the United States for his abstract entitled Tuberculosis Preventative Therapy in PEPFAR Countries. Anura David of South Africa for her abstract entitled Evaluation of a Prototype COBAS MTB Assay for use on the COBAS 680-8800 system for the detection of Mycobacterium tuberculosis in a high-burden HIV patient population. And Andrew Fulham will represent Sean Curtis of the United States for her abstract entitled How does integrating HIV and TB services affect health outcomes for HIV-TB co-infected patients in the Ukraine? Results from an impact evaluation. And Sabina Muguzi of Tanzania for her abstract entitled Efavirenz Plasma Exposure and Immunological Outcome During Anti-Tuberculous Co-Therapy, Role of Ethnicity and Pharmacogenetic Variations. Please join us in congratulating their contributions to TB-HIV research.